discussing this. We will be discussing obesity topic in a different way, like we did yesterday. Diabetic ketoacidosis. Just a second. Okay, so first of all, if we just try to see which procedures we can do or we can encounter in obese patient. This is our one target number one, and the other will be that what will be the challenges while anesthetizing an obese patient. Am I audible to you people? Can you hear me?
Yes, sir. Yes, sir,
Yes.
we can hear.
Okay, so if we, for example, if we start with the challenges, we have a obese patient. Okay, so what number one will be the challenges? Okay, how to like for example quantify. Okay, then there will be another thing will be how to calculate doses, equipment. Okay, and there will be some terminologies like calculate. When we say calculate, there is how to for example, if you have a patient who is quite obese, so how will you calculate the dose on the basis of total body weight, ideal body weight? Okay, or there is another common terminologies will be three, this lean body weight. Okay, so this is one thing. Another thing is that what are the common procedures? Any elective, any emergency surgery can be occurring, but specifically what procedures you can encounter in obese patients. Okay, so this will be another point. The challenges like will be in systemic challenges in first of all, what are the changes? Okay, and what are the modifications? Okay, like you need to do in your in anesthesia. Please, can you mute yourself, please? This is please mute yourself. Whosoever is not unmute, please mute yourself. Okay. So I'm just giving you an just a sketch about what you should be knowing when you are dealing a obese patient. Okay. Okay. So who want to volunteer? Just raise the hand. Mamuna or Zishan, but who wants to volunteer?
Yes, sir.
Okay. So Zishan, if you just, what is the concept of ideal body weight? Like, for example, you have a patient, you weight and the weight is 170 kg.
Sir,
Okay. So what in other information would you like to have other than weight? You would like to have
height of the
height.
patient,
Okay. So that will be important to calculate the BMI.
ideal body weight.
No, BMI. BMI as well as, yes, ideal
Ideal.
body weight. Okay. So ideal body weight, maybe there will be a lot number of formulas, but one is the total body weight minus, sorry. Height,
Height
height,
minus 100.
height in
Height in centimeter
centimeter
minus 100 in males and
minus
105 in
100 in males and 105 in females. For example, if you have a patient with a 180 centimeter and the weight if it's a male patient, so the ideal body weight is 80 kg. Okay, this is a concept. So the other one, so ideal body weight, total body weight, and third one which is important, there are by the way, there is one predicted body weight, there is one adjusted body weight. Unfortunately I don't have very good concept. Lean body weight is relatively simple. So it is the ideal body weight plus 20 to 25% of ideal body weight, that is for body fat. Okay. And actually, if you don't remember anything else, so lean body weight is the majority anesthesia medications which we give is on lean body weight. Okay. So for example, if you have a patient with 180 kg for 170 kg, so even then, there is a thing that you will not take more than 100 kg as lean body weight, even if it is more than that. So you will maximum take 100 kg as male and 70 kg for female. Am I right, Zishan? Is it like this?
Yes, sir. Yes, sir. It's
Okay. So this is the basic concept. Another thing is that, so this will be give you, like, if you have a patient on bed and you don't have the weight, so maximum you will take 100 kg for a male and 70 kg for female. Okay. And ideal body weight, we have already discussed that it is height in centimeter minus 100 for male and 105 for female. Okay. So this is another thing that, so this will be guiding you. So among that, we will just see the text as well to see the further as we did yesterday. But usually the water soluble drugs, which, like, for example, muscle relaxants. Okay. So you can take on lean body weight or even ideal body weight, because this is related to the because they are water soluble, and the fat soluble, like induction agents. Okay. Sometimes they can be taken as total body weight for, like, for example, propofol. Okay. Maybe this patient might be needing the induction doses higher, but the maintenance will be according to lean body weights. So this is a concept, basic concept about it. Exception for this rule is suxamethonium. Suxamethonium is usually has to be calculated at total body weight. Usually, because if you are calculating with this lean body weight, sometimes the dose is required more. There are so many other factors for suxamethonium. This is just a basic concept. Okay. So number one, this will we covered some aspects of medications. What other challenge we have? First of all, because we have started in a different way, so what will be the other challenge? Logistics, we will be doing the simple thing. What are other logistic challenges, Ishan? Logistic challenges means what else would you be facing when
Sir,
you are
number one, shifting the patient, appropriate size of the table for the patient, appropriate size
slow, be a little slow. Okay. Shifting. Okay. Shifting from the bed,
to the
from the
operating table.
trolley to the bed, and even the bed you requires maybe a bigger bed. Okay. Special bed for such patients. Okay. So this is one thing. Other thing,
Sir, our equipment, appropriate size masks, appropriate size
where it has gone.
laryngoscopes, and then our ventilator should be compatible to be dealing with those high pressures and everything.
Okay. So probably you need pressure control ventilation. You should have special size BP cuff. Okay.
Cuffs.
BP cuff. What about the possible difficult intubation to challenges is ramp position? Do you know about ramp position?
Yes.
Okay. What is
Rapid airway
because
maneuvering.
for many years I used to think that it is ramp, the virtual word ramp, but this is the ramp position. Okay. So, and this position is needed. Even you can use this, and this is, I'm just telling you something practical, that if you make your habit to intubate in this position, okay, or a position similar or near to this position, you will have easy intubation in any patient. So it is not necessarily obese patient. If you do it even in any patient, you will face much more easy intubation. Okay. And what is the concept? That you have to bring the external auditory meatus at the level of angle of Louis or angle this sternal angle. Yes, Dr. Suhail, what you are asking? You raise the hand.
Sir, ramp position थोड़ा सा एक बार बता दें sir, please. Thank you.
Ramp position in which you see
Yes.
you have put a pillow in a way that you are raising the head side. There is, you see, there is more elevation here.
Okay,
I
sir.
cannot write here. On this part, there is more elevation over here. Okay. Then
Okay.
there is
Basically,
more
the chest
elevation.
chest is also risen, and
Okay.
the concept is that sternum and the tragus of ear should be on the same level.
Okay, sir, ये जो हम आमतौर पे करते हैं difficult intubation में
Try,
कि हमारी ना
Suhail, don't mind, please try to talk in English. We have some international speakers over here. Yes, please.
Okay. So sometimes we consider in difficult intubation just like in peds. So we put
Yes.
some sort of wedge behind under the shoulders and
Okay.
make the position. Is it that thing or something else?
Actually, in pediatric, the things are a little bit different. We are talking about adults. Pediatrics, actually, the architecture are a little bit different. They have short neck. You cannot do this position in a very nice way in pediatric. Okay, but the concept is the same. You know what is the concept?
I mean something. I just wanted to ask that we just put some sort of wedge under the shoulders, like in difficult intubation. Is it that sort of thing?
Not exactly.
We put something
Okay.
just behind the under the head.
Just a second. I will explain in a better way. Actually, there is a specific Oxford pillow. I will show you the picture of this Oxford pillow, which is especially. Just a second. No, it's not Oxford pillow for.
Picture is on the SOBA guideline page also.
You know, this is Oxford pillow. Okay, this is Oxford pillow specifically for men. And you know what is the purpose for it? Let me explain to you that the purpose, actually, this is not related directly to this topic, but I will just try to explain that you have three angles. One is oral angle. Okay. Other is pharyngeal angle. And the third is laryngeal angle. Okay. When you want, you have to, like, I'm very bad in drawing. So one is this, and one is this. Okay. So this is laryngeal angle, this is pharyngeal angle, and this is oral angle. Okay. The purpose of our optimized intubating position is that you want to align these angles like this. Okay. So any maneuver or anything which you want, which you have to do to make these angles straight, that is what is the aim of putting something under the head as in pediatric, or elevating, because you just imagine an obese patient. There will be a big chest, the head will be down, the chest will be up. And similar condition is there in a pregnant patient. And large breast tissues, and they are hanging, coming towards the chin. Okay. So if you make the position like that, as mentioned over here, okay, so what will be the advantage? Just a second. Where is it gone? Yes. So you are elevating the this external auditory meatus. Okay. You are elevating up to the angle of Louis. It is angle of Louis or sternal angle. Okay. So you are making a ramp. You see, this is a ramp like this. Okay. So in virtual moving, but it is the ramping position is for rapid airway management position. This was, even I came to know very late that it is rapid airway management position. Okay. It is ramp, R-A-M-P. Okay. So what other thing, Zishan, can we do?
Regarding airway?
Yes.
Sir, we should have provisions for difficult intubation.
What
the
about
different
awake fiber
sizes of
optic?
awake fiber optic.
Awake fiber optic, difficult like gyroscope
Yes,
or
sir.
video
The McCoy and all the
laryngoscope,
other blades,
McCoy, okay,
and someone should be
LMA,
there for help
LMA
also.
or other supraglottic airway device, iGel, okay. So awake fiber optic may be academically answer in difficult airway in morbidly obese patient, okay. So a ramp position, airway, awake fiber optic. This will be the answer to the challenges because of difficult airway you can suspect in obese patient. Okay. So we up till now we discussed about medications. We discussed about logistics. We could just discuss about some of the things. For transfer, there is a maybe it's not available.
Lift.
Yes, there is a slider. Okay, there is a slider which can be used to transfer from one there. That they turn the patient slightly. They put the slider, and then with the slider, it is just slide the patient rather than lifting. Okay, because if you lift the patient, then sometime it becomes difficult to. Just a second, please. Okay, so sometimes it is difficult. Okay, then another logistic issue. We are only dealing with the logistic issues. Difficult IV lines. Okay, for that you need maybe ultrasound. Okay, vein visualizer. Okay, so to deal with vein visualizer, you need to have sorry, for difficult IV line, and ultrasound also for one other purpose, Zishan, especially which maybe you will not be using in other patient, for central neoaxial block.
Yes, sir.
Okay, ultrasound to measure the midline. Where is midline? How much is the distance between skin to space? And what is the third answer, Zishan, which we will be looking in ultrasound? One is midline. Where is midline? The other is distance between skin to the space, epidural
So,
space, or yes, Mamuna, please tell.
There is also another use of ultrasound that can be for the confirmation of
You know, unfortunately,
ETA
Mamuna, your
as
voice is
well
distorting. We are not.
as
I'm.
confirmation of the space can be done.
do in
Yeah.
Number of
COVID pandemic.
Unfortunately, her voice is.
Hello,
Mamuna,
sir, can you hear me?
No. Now we can hear you, but we couldn't hear a few moments ago. What did you say? Please say again.
I said there is also another use of ultrasound that is for the confirmation of endotracheal tube.
Okay, we will do, but specifically there is one more thing which you need for central neoaxial block. One is to identify the midline. Okay, one is to measure the distance between skin to the space. Endotracheal tube is correct, but there is one more thing, is to identify the number of space.
number of
Okay, because you will be starting from the sacrum and then you will go up. So, you know, I tell you, this is slightly lateral discussion, but you know, when we put our fingers by curving our hands, what is the space which we get usually?
L3 force.
L3, L4. You will be surprised to know that you are only there and 1/3 times. In
Yes.
1/3, it is higher, and 1/3 it is lower. So in 33% cases, you are correct. In 2/3 of patients, you are wrong. Either you are one space up or one space down. So one space down is not a problem. But if you are one space up and you tried and then you go one space more up, then you will be in trouble because you can enter the spinal cord. Okay. So that is actually the rationale behind this thing. Okay. So yes, ETT is another thing which you can confirm the tip. What else? Now you have told this thing. Now we will finish the topic of ultrasound in obese patient. Yes, Mamuna, I would be expecting the answer from you. There is one
Gastric
another
volume.
thing related to airway. Dr. Liaquat is expert of it.
Gastric volume.
Very good. Let her talk. I have high expectation level from the student of my teacher. Residual gastric volume. Okay. You know about this, Memuna?
Yes, sir.
Okay. So you can measure the residual gastric volume. Another thing is that you are not able to identify the lung sounds. Okay. So maybe you can check the lung ultrasound to see any evidence of pulmonary edema. Okay. There are some lines. I'm not expert about it. Even if you know about this thing, it's more than
These
enough.
are called B lines, sir. B lines.
B lines.
It's prominent, yes, used
B
in
lines.
pulmonary hypertension also, and in a patient with
Not pulmonary
hepatic-
hypertension, Jamil. Pulmonary edema.
in pulmonary edema and in hepatopulmonary syndrome also. It's
Yes,
prominent.
that is also overloaded. You said pulmonary hypertension. So it's not pulmonary hypertension, it's pulmonary edema or any overloaded state. Okay. So now you understand I'm trying to cover, because actually sometimes when you are discussing something, a number of things come. So up till now, I'm just trying to recap all every other minute. Medications. Okay, logistics we have discussed about shifting. And yes, now regarding blood pressure? So it is difficult to have the appropriate cuff size. Ishan, how to calculate the cuff size, by the way?
Sir, the appropriate cuff size is the width of the cuff should be 2/3 of the circumference of the
This is
arm.
elbow, this is shoulder. So the one thing is the length. So how much should it be in this direction? It should be covering
Length
the
should- 1/3 of the arm.
no 1/3 or 2/3.
This distance is 1/3, I think, and the circumference of the arm, the width of the cuff should be 2/3 of the circumference of the arm.
Any other comment, Mamuna?
Sir, 40%.
40%. Okay, Jamil. J dot.
I know the size of the cuff. There's inside the cuff there is one bag. Yes.
Unfortunately, your voice is distorting. Unfortunately, I'm happy in this way. The thing which I forget, Alhamdulillah.
Sorry, the bag actually in
Just
cuff,
check it.
BP cuff, the cuff, they're inside the bag of
Okay.
made up of rubber. This should be 2/3 of the arm circumference.
No, Jamil, listen. There is one diameter like this, and there is circumference is like this. Okay. So there are two different things. One is the length
I
of
am
the
talking,
cuff.
sir, about the circumferences, like
So-
more than.
Yes, this should be more than 2/3. That's what I know.
Yeah.
But what about this length? There is a confusion in this thing. Zishan is saying
2/3.
1/3.
2/3 likha hua hai, sir. It's written
Yes, so
2/3
it is also 2/3.
in the
Okay.
length.
Look, yeah, 1/3 is smaller thing. I think it would be smaller.
So
At least
both sides
2/3
it
or more
should
than
be
2/3 at least.
2/3.
Yeah.
Okay. So this is difficult to get. And another thing is that because these patients are prone to injury, nerve injury, they are more prone. Okay. So if you keep it, and another thing is that they may need, because the cuff is very big, may need more pressure. Okay. So it is better if you can take intra-arterial blood pressure. So that will be accurate, easier. Okay. So this is another thing. So regarding the blood pressure, this is the challenge which you will have. And of course, these patients will be at more risk of hypertension, and rest of, we will discuss these things, because the other things you always read, but these things you never read. So I'm trying to start with the things which you don't read, or we have a lot of confusion, and even the books have not stressed these things, which are more important practically, as well as it will be written in the, definitely it will be written in the key. So if you are missing them, you are losing the numbers. Okay. So any other logistic thing, these patients will be like, you should be maintaining.
Sorry, actually, I joined late. What about the OT table? Already you have people that talk about the
Yes.
OT table and some surgical
Yes, we have
instruments needs
discussed,
specific
this
surgical instrument.
is,
Yeah.
yes, this is the your favorite topic of men, we have already discussed. Okay.
Personal yes, sport. At least 6 people for the general population, but here we need more muscular people. Yeah.
Okay. Okay, so we have to maintain the normothermia, because these patients will be. What about this thromboelastic dresses or pumping? Because these patients are at risk of venous thromboembolism. Okay, so you have to maintain. There are, you know, about, anyone knows about this thing? There are pumping devices to reduce the risk of venous thromboembolism. Okay, so in these patients, you need to have.
The cuff like yes, attached
Intermittent
to
pneumatic
legs.
compression.
Yeah,
Yes,
intermittent pneumatic
I was
pressure,
not finding this word.
compression.
Pneumatic
Yeah.
compression. Okay. Compression devices. Okay. So this is another thing which you should be knowing. I think we have covered most of. If any logistic thing we have missed, we will just discuss later on. Okay. So now, just a second, few words. And anyone else, please, anyone else want to contribute? All of you are welcome. Whosoever wants to speak out, just raise the hand. Who wants to volunteer, please, other than Mamoona, Zishan, and Jamil? Anyone want to volunteer? Just let me know. Otherwise, I will have to ask them. Okay, Zishan. So what will be the, now we will be discussing about the, like, for example, first thing you said that weight. Okay. Then you calculate BMI, BMI. Okay. And then now you have to classify about according to the WHO classes. We will be going to the numbers later on while we will be seeing. So now you say that it is obesity class 1 or 2 or 3. Okay. So now you, for example, it is class 3. Okay. So what else would you like to see? What will be your evaluation will be targeting with the
System wise, we have to see all the systems. We have to see the airway, then respiratory system, CVS system.
what about stop
GIT.
bank?
Stop bank, of course, OSA, it comes in the respiratory when we are
No,
assessing for
because
the respiratory.
whenever you have obese patient, okay, we can go side by side this thing. Just a second. So because I am very bad in numbers, so I always get the help. So this is how you can classify obesity: class 1, class 2, and class 1, class 2, and class 3. Okay. So this is
Yes, sir. Depends upon the BMI, the normal weight. If you want, I will classify. And normal weight is according to BMI from 18 to 24.9, and overweight is called as 25 to 29.9 BMI. And if BMI is from 30 to 34.9 is classified as grade 1 obesity. From 35 to 39.9 is grade 2, and above 40 categorized as grade 3 obesity.
okay, and there are some non-classifiable words like morbid obesity. So usually morbid obesity is more than 40. Okay, and
Super obesity, yes.
super obesity is more than 50. Okay.
Yes.
But usually this is not the failing points. Remember, these points are not failing point. You should be knowing at least one of them, and then you can add on if there is something. So if you have a patient with the high BMI, Zishan, we will be evaluating the patient to rule out first of all these things. So this is the stop bang questionnaire. You should be knowing snoring, tiredness, observed apnea, okay, and pressures, and then
Fever,
bang is
pressures, yes.
BMI, age, neck circumference more than 40 centimeter, and male gender. Okay. So if you have more numbers, you have more risk of OSA. For example, if you found to have OSA of 5, oh sorry, this stop bang number is 5. What will be the next step, Zishan?
Apnea hypopnea index.
Very good. Okay. So you will be doing the sleep studies. Okay. You will be doing the sleep studies. We will discuss later on what is this concept, but for now you will be calculating that, because you know the thing is that bookish knowledge is bookish knowledge. You have to convert into practical. Okay. You send the patient for sleep studies, and after that you don't know what is the interpretation. So interpretation is the total number of apnea or hypopnea in 1 hour. Okay. Apnea hypopnea index is the total number of apnea or hypopnea. Apnea is complete cessation and hypopnea is incomplete cessation with the decrease of saturation. I'm trying to make it simplify. You will be finding for 10 seconds, more than 10 seconds, and more than 5 seconds, incomplete or complete. But the bottom line is that one is complete cessation, other is incomplete cessation with decrease in saturation. So this is the concept. And then you will be quantifying according to the number of AHI numbers which you are getting. It is mild, moderate, or severe. Okay. So now if you found to have.
Sir, if you allow me, sir, I can elaborate about this sleep study, about the sleep apnea and hypopnea index. It's actually the carried out in
A
specific
little loud.
centers.
You have to be a little loud.
Now is okay, sir?
Yes.
Yes, this sleep study, when there is first we calculate the stop bang. If it's also we help in the selection of the patient. If stop bang is 1 to 2, we can proceed patient as it is surgery also, and patient as any elective surgery also. If it's 3 to 5, then we have to rule out the patient about pulmonary hypertension, or patient is maybe taking any CPAP or IPAP. Then we have postoperatively send the patient to HTU. If more than 5 stop bang, then we send the patient for sleep study, and according to that sleep index, we then postoperatively manage the patient to HDO or to ICU, or patient may need non-invasive ventilation, or might be patient go after surgery to the ICU for mechanical ventilation. The sleep study carried out in specific centers where they observe the respiratory pause, means expiratory pause. The patients monitored induced by specific agents for the sleep. They just put something, some pads on the eyes, and it induced the sleep, artificial sleep. And then they put the mask also on the face mask with the end-tidal and pulse oximeter, ECG, and EEG also, to monitor the depth of the sleep. If the patient sees completely his breathing or expiration more than 10 seconds, or it decrease of saturation more than 9 or less than 95 for 10 seconds, is called as a apnea. Or if it's decreases the flow more than 50% for 10 seconds, or also decrease the saturation more than 95, it's called as a hypopnea. Then they calculate the index how many times in hour. If 5 times is normal, in population, up to 5 times some hour is considered as a normal in healthy population also. And from 5 to 15, it's considered as the mild index. If there is hypopnea or apnea, 15 times hour. And from 15 to 30, it's a moderate, and 30 to 40, sorry, it's considered as severe. Yes, severe
Remember
index.
one thing. Remember one thing. I will. You have elaborated very nicely, but I tell you something. In the table viva, or even in long case, nobody will ask you how to do it. Okay. So try to
Yeah,
not to
definitely. I just
not to go.
sharing knowledge. Yes.
Yes, you are absolutely right. But I'm just telling you because if you try to tell the details, maybe you will miss the questions. Okay. So this is one important thing which you were mentioning. And now I will mention that if the AHI index is higher, you will be sending the patient it HDU like this. So this is also a question which should we maybe asked in any part in of exam. So what is the level of care? So patients who need can be met through normal ward care. This is level 0. Okay. If patient at risk of their condition deteriorating and those recently relocated from higher levels of care who needs can be met and cured with additional advice or support from the critical team. This is level 1. Okay. Then level 2 is HDU actually, requiring one more detailed observation or intervention including support for a single failing organ system. Okay. Single failing
Except
organ
respiratory.
system except respiratory. Okay. So
Yes,
this
sir.
is actually if I can write it as level 1. Level 0 is something which is actually our patients in government hospitals sometimes are always in level 0. There is no difference between level 0 and level 1, but actually they consider level 1 as ward, level 2 as HDU, and level 3 as ICU. So what is different? Some people they can ask you in the exam what is difference between HDU and ICU. So the difference is that in HDU you can have only one organ support other than ventilation. Okay. And if you have, for example, if the patient is needing inotropes and the patient is also on dialysis, so there are two organs involved. So this patient should be in ICU. In some hospitals, there is no difference between HDU and ICU, but in good setups, there is one place is written as HDU and other place is written as ICU. So this is what was just mentioned by you regarding the sleep studies. Yes, you told in elaborately maximum they will ask you for how much duration, for how many times with decrease in saturation. That's it what you should be knowing. Okay. So
And just want to, and in some hospital, it's called as a step down. It's
step
between
down as well.
ward and ICU. Yes.
Yes. Okay. So okay. So just a second, please. Okay. So Zishan, anything else about this thing which we have discussed? Any you want to add any other point?
Anybody
Yes.
discussed about the drugs and their
We have discussed drugs,
those according?
Jamil. Jamil, just a second,
Yes, sir.
please. We have discussed drugs. So now we will just try to cover the systematic effects. So we discussed about that we have an obese patient. We quantify it. We ruled out stop bank according to stop bank criteria. We refer to for OSA, rule out OSA, and now we are dealing with the systemic. So how will you how will you explain what about CVS, CNS, respiratory, okay, endocrine? Yes, Zishan,
GIT.
GIT. Zishan, you want to speak out?
Uh, Sir, in all systems, there are certain problems.
Yes, so
Like in
CVS,
respiratory system, first of all, this
okay,
was
respiratory
OSA.
system,
Then the FRC is reduced in these patients. There
okay,
are difficult airway problems,
high airway pressures,
airway pressures.
okay. Is there any effect on lung compliance and
Yes,
Um,
it's
chest?
the patient considered
lung
as a
compliance.
restrictive lung disease patients
Yes,
due to high
that is
fat
correct.
weight on the chest wall.
So this is chest wall compliance, not lung compliance. There is no effect on lung compliance, by the way. Okay. There is two different things. One is lung compliance and one is chest wall compliance. So because of fat, there is decrease in chest wall compliance. Okay. So airway pressures will be higher. Just correct me if I'm wrong.
Yes, no, but it's considered as a restrictive lung disease patient. Yes, because there's total overall their chest cannot be expanded due to the heavy weight on their chest wall, due to obesity.
Okay.
And the
Okay.
second is they are prone for the atelectasis also.
Yes, just a second. Okay. So okay, so they have labeled it because my concept was I just wanted to correct it. My concept is there is more effect on chest wall compliance and lung compliance. Anyways, you are right. Okay, so the atelectasis, why there will be chances of atelectasis? Yes.
Diaphragm is splitting due to the heavy organ contents of the abdomen, and they push the diaphragm up, and there is risk of atelectasis.
Due to
Oh,
that.
yes, please.
Diaphragmatic splitting.
Yes, who was talking? Who was speaking? Okay. Okay, so any other change in respiratory system? So as a summary, there is FRC is reduced. There is more airway resistance, restrictive like disease like pattern, and there is more AA gradient. There are more chances of atelectasis. Okay, and more chances
Hypoxic
of
drive. They have a hypoxic drive.
hypoxic drive. Okay, what do you mean by a hypoxic drive?
Hypoxic drive mean, they
Unfortunately,
have a
Mamuna, I apologize to you.
baseline
Your voice is not visible, not audible to us.
high
Your voice is
pressure of custodial. Sorry.
your voice is distorted and we cannot listen anything.
Sorry, sir. I will try to.
You can write.
Hello.
You can write it down.
Maybe
You
it
can
is
write it
due to
down.
signals or maybe my mic. I will change it.
Okay. So now
Is it not
now
clear yet?
are you talking
Okay.
through
Okay. Okay.
headphones? Are you talking through headphones or you are talking directly through mobile? Okay. Anyways, so now Jamil, how will you evaluate? Because we will not be only looking at the point. So how will now this respiratory system? How would you like to evaluate? Yes, Jamil.
Inspection, auscultation, and some help of other tests like spirometry and spirometric. So now we can calculate about all the other parameters for
What
the
about X-ray? What about
chest
X-ray?
X-ray.
What about
Yes,
ABGs?
yes, ABGs also we rule out the hypoxia, hypercapnia with the
Okay.
ABGs. In the chest X-ray also, we also
The word which Mamuna mentioned about hypoxic drive, that is because how you can see with the ABGs, the resting ABGs. Okay. Because, for example, if these patients have high CO2, for example, as it can occur in case of like hypoventilation syndrome, obesity, hypoventilation syndrome, and then leading to this OSA, this metabolic syndrome. These all are associated, correlated things, and pulmonary hypertension. Okay, so you have to take a baseline ABGs. What about chest X-ray? You have to do chest X-ray, spirometry to see FE1, okay, and FVC. If you, of course, you will be doing it if needed. Not in every patient you are required. If you find any decrease in metabolic equivalents, METs, you will be evaluating the METs, and then you will be you can do these things. Okay. Okay.
for
Now
obese
come.
patient with some respiratory disease, we also then go for spirometry.
Yes. Now comes to CVS. So what will be the effect on CVS?
These patients have high cardiac output. They are hypertensive. They tend to develop ischemic heart disease, cardiac failure, etc.
LVH,
Subsequently, arrhythmias also. LVH, of course.
LVH, LV failure, CCF, okay, cor pulmonale, okay.
Or pulmonale, why, sir? Mostly this is left ventricular failure.
Yes, but why
Or
pulmonary
pulmonale is
hypertension
right.
occurs?
Okay, why?
This will lead to the same mechanism. The same mechanism. When there is OSA, what happens?
Hypoxia,
Yes.
sir.
Hypoxia and hypoxic vascular pulmonary vasoconstriction.
Please
Hypertension.
speak. One
Then
of them speak. If two people speak, then there is distortion. Please, Jamil, speak out, or Hamza, you speak out. Yes, Hamza.
Sir, there will be hypoxia, and because of that persistent hypoxia, the pulmonary vessels will constrict, and because of that, it leads to pulmonary hypertension.
Yes. Okay. So this is the mechanism of cor pulmonale in obese patient. Zishan, are you clear now?
Yes, sir. I understand.
Okay. So that is what Maimuna mentioned, that you have to maintain, you have to consider hypoxic drive and hypercapnic drive. Okay. Because both of them are very important. The picture is similar to COPD, not exactly COPD, but it is the same concept which we face in COPD. Okay. So you will be doing ECG, and if you have some risk, some positive findings, you can go for echo. Okay. But simple morbid obesity is not the indication for echo. Remember one thing. You can say that if you find some finding, if you have some ECG findings, or you have some functional problem, METs, then you will go, or there is risk factor like insulin dependent diabetes mellitus or angina. We have discussed number of times. Then you will go for echo. Okay. So this is the correlation. What else? So you see pulmonary hypertension, right ventricular hypertrophy, right ventricular hypertension, and then cor pulmonale. Okay, blood volume is increased, cardiac output is increased, ventricular workload is increased, oxygen consumption, myocardial oxygen demand supply ratio is disturbed, left ventricular and diastolic pressure are high, prone to ischemia. Okay, so and in ECG, low voltage complexes because of too much fat in the chest. Okay, and LV strain pattern, segmental wall motion abnormalities, and then if there is some ischemia or infarction, then there will be global hypokinesia, or there will be failure. Okay, and right bundle branch block and P pulmonale as can occur. This is normal. This is not a, don't try to cram all these. The concept is the same. Whenever there is stress on the heart, there will be changes on both the chamber, both the filling pressure. So there will be disturbed myocardial oxygen demand supply ratio. So anything can occur. Okay. So this is okay. So we have discussed these things. Suxmetonium on actual body weight, as I told you, and propofol in intubating doses. Usually, induction doses can be on total body weight. Otherwise, usually yes, when we discuss about this central neurological block, we told about the use of ultrasound and use of bigger, longer spinal and epidural needles, more than 10 centimeter. Okay, the usual wind law will not be used. So we have actually discussed a number of top system. GIT, there are more chances of stasis and aspiration risk, difficult airway also and then endocrine will be there, more chances of diabetes mellitus. Okay, as occurs in metabolic syndrome. Am I right? Okay. And Jamil, have you just revised the terminology, because I always forget them? OSH, OHS. You see, these are two different things. Then what is the name of the syndrome?
Pickwickian syndrome.
Pickwickian syndrome. Okay. Then metabolic syndrome. These are the terminologies which you should be knowing. OSA and OSH is the same, like obstructive sleep apnea and obstructive sleep hypopnea. What is OHS?
Obesity hyperventilation syndrome.
Very good. What is components of it? Daytime somnolence. And what else? Because I have not read them for a long time,
Tiredness.
and practically it is not very important thing, but you just confirm it. What is OHS? I think it has, if the failure occurs, then it is Pickwickian syndrome with cor pulmonale. I am just trying to recall, which I read many years ago, I think. OHS plus cor pulmonale is Pickwickian syndrome. And this all these components along with diabetes mellitus, it is metabolic syndrome, something like that. But
Metabolic syndrome.
I'm just telling you, you should be knowing these
Yes.
terminologies. Okay. Okay, so in addition, when discussed about these things, so you will be expecting some extra care as we discuss about HDO or ICU, need of post-operative ventilation, and important things, need of CPAP. Okay, used, maybe patient might need CPAP or BiPAP. Okay, so you can do preparing the patient with, you can have incentive spirometry, or you can have some optimization related to heart failure or treatment of hypertension, or like improving anything which it is in your hand. So you will be optimizing the patient, and you can discuss with the surgeon about the surgery, whatever surgery they are doing, trying try to have minimum invasive surgery. Okay, try to have minimum invasive surgery. And then we have discussed a number of things. I will just discuss about analgesia later on, a little while. Yes, Mamuna.
I was like about to talk about the good analgesia,
Yes,
because
I will just try to explain analgesia.
Usually
No,
these patients, if are coming for abdominal
ma'am.
surgery, pain control is very important, because
Yes,
because we know that. Yes, and other than these, under anesthesia, nerve injury. Hello.
yes, Mamuna, I am really sorry, your voice, we cannot hear you.
Other than these things, under anesthesia, these patients are very prone to have nerve injuries, even bruise.
Yes, I think Mamuna, we are not able to listen to you. Just write down in message, and I will try to answer. Okay. Okay, so we have almost covered almost all the aspects. Analgesia, I will just, let me show the slides which we have, just to see anything we have missed, and I will talk about analgesia, and then we will finish. So as I told you, that lean body weight, these all charts are there in the link, and you can have a look at them. Let me see if anything which is what is important I did not tell you. Yes, neuromuscular monitoring you can do, because on and general principle is that you try to use the medication which has less metabolism. Okay, because the fat soluble medications, if they go to in the fat, they take more time for the recovery. Okay, so similarly, if the medications have more metabolism and delayed chances of delayed respiratory depression, so you have to make a balance between risk versus benefit, and you have to titrate, because if you don't control the pain, then it will be causing the splinting, atelectasis, and respiratory problems, all of them. And if you overdo them, then it still be a problem. So PCA with opioids, with fentanyl, or even morphine is not absolutely contraindicated. You have to outweigh risk versus benefit. Uh, and rest of the things we have actually, I think all of these things we have discussed. Okay, just a second. nerve injury you were talking about, it was the correct thing. It's very important thing. Okay. Yeah, this is the obesity guideline. You can have a look and you will find the most important things. You will just have a look on the recommendations. Okay. That's the same thing which we have discussed: fat distribution and respiratory change in respiratory system. Okay, cardiovascular system, thrombosis, diabetes. Yes, actually, the place of obesity is also important. Truncal obesity and lemon on drumstick appearance, and especially the cause of obesity. Obesity may be caused by some metabolic problem. Obesity may be caused from other day I was asking someone, is there any brain tumor which can be associated with obesity? Yes, please. Anyone?
Pituitary.
Tumor.
Pituitary tumor, growth hormone secreting, or it is ACTH secreting tumor. Okay.
Okay, sir. Okay, sir.
So even if you are talking about brain tumor, you can, as I was telling you, this is, don't try to learn these things. You will never be able to reproduce it. So better I only recall this thing which I now remember even after 4 years. Okay. Not 4 years really. I'm getting old. 5 years. 5 years ago I did FCI, so I lost read these things. Okay, so 100 kg for men and 70 kg for women. Adjusted, can anyone tell about what is this adjusted body weight? I don't have the concept. Jamil, can you explain what is adjusted body
Adjusted
weight?
body weight is ideal body weight plus 40%.
What do you mean by 40%?
20%. 40% or 20%?
40%. But the thing is that, what is the significance? Anyways, don't try to learn it as necessary. If you are able to do it, fine. Otherwise, if you try to have too much stress on it, maybe you will not be able to understand even the lean body weight. Okay, so lean body weight is more important thing than total body this adjusted body weight, and there is another concept of predicted body weight. Okay, so please, I think we have almost covered all the aspects. If there is emergency surgery, you have to proceed with risk stratification. If there is elective surgery, other than bariatric surgery, you can have planning for that patient. You can have some weight reduction. You can plan for the things. You can optimize the things. Okay, and then you will proceed. Okay. Otherwise, you will be preparing the patient in a nice way. You will be discussing with the surgeon, and you should have a full-fledged plan. If you read this guidelines only in a bird eye view, no need to cram and read everything. You will find almost the things which I have discussed with you. Okay. Supraglottic, use of supraglottic airway devices, and anything, Zishan, which we missed, please, before we finish.
Mostly the intraoperative things.
Even post-operative, we have covered almost everything. This is because of crush injury, because they are prone overweight patient. They have reduced intravascular volume, so they are prone to dehydration and everything. If you give too much fluid, they can go in overload as well. Okay, so sedation, emergency surgery, day. Yes, they can ask you about day surgery. Is day surgery contraindication for obese patient or OSA?
Depends upon the grading, sir.
Grading. For example, if patient has mild OSA, can patient have day surgery?
Yes, we can proceed. Yes.
Okay. And for example, if the patient has some surgery, like it's not contraindicated. The message is not that it is not contraindicated. Okay. You will be outweighing the risk versus benefit, and then you will be handling it. Okay. So I think it is enough for today. We will discuss some topic tomorrow, inshallah, hopefully same time. Okay. You can have a look. I will just share the link for this folder, and actually you will find everything.
Excuse me, hello, sir. Can you hear me now?
Yes, yes, yes.
Hello.
Yes, 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 please.
Yes, I was talking about the extubation plan, which is also important.
What is that?
Because we usually place the nasopharyngeal airway
Okay.
prophylactically before extubation.
In patients
Nasopharyngeal
with,
airway placement before extubation.
yes, yes,
Planning for extubation.
yes. This is to prevent the tongue fall. Yes, this is absolutely right. Actually, you will be ready for, you will be anticipating for post-operative problems. One of them is airway obstruction. Okay, so you will be extubating awake, and you can have this provision of nasopharyngeal airway and even oropharyngeal airway, or like you. That's why I tell you that you have to use the medications with less hangover. You have to get a very good analgesia. Okay, you don't have to correct the this one. Just a second. You don't have to do the you have to keep in consideration the baseline CO2 and everything. Okay. So, actually, I'm just trying to cover the more important topics. So tomorrow, we will just have a basic concepts of pediatric anesthesia. Okay. In the similar way, like we did obese patient. Okay. So thank you very much. And any questions, you all are welcome to drop any question on WhatsApp. I will be able to answer to you. Okay.
Thank you, sir.
Thank you very much. Assalamu alaikum.
For the question.